website along with the slide deck, probably in about 5 business days. All participants have been muted upon entry into the call, but we do want to hear from you. So you can drop any of your questions or comments into the chat, and we will take some time in between speakers or at the end to go through those. So some ways to spread the best practices from what you'll hear today on the LAN call. You can share your approaches and experiences via the chat. You can identify how today's information could be used at your facility. You can apply at least one idea from today's LAN call at your facility, and you can commit to sharing your learning and ideas with other colleagues. So just a quick polling question before we get started, and you can use the chat for this. Have you previously used the best practices from the change package to improve your clinical outcomes? And even though this is the depression call, how about, we can be open to anybody. If you've used any of the ESRD NCC change packages, we'd love to hear from you. I see yes, some no, good. Okay, great. Yes, no, seems to be kind of a little bit of both. So that's fine if you have it. Hopefully at the end of the call, you'll have a moment at some time and take a look at them, go to our website and check out our change packages. So we're going to jump right into our first presentation. Lisa Hall is from ESRD Network 16. And Lisa, I'll move your slides, so just let me know.
Okay, thank you. Thank you for inviting me to present today. I'm based in Seattle. We cover 5 Pacific Northwest states here at ESRD Network 16. Recently, my colleague, Beth Whitten, who most of the social workers on this call probably know, posted a blog for Medical Education Institute on how to survive and even thrive during the holidays with a chronic illness. The overarching theme of her blog was gratitude, and it really sparked my interest to learn a little bit more about the topic. Next slide, please. I love this quote from Piglet, from Winnie the Pooh. Piglet noticed that even though he had a very small heart, he could hold a rather large amount of gratitude. That makes me smile. Thank you, Anne. Next slide, please. So in a 2017 study, gratitude actually predicted lower depression in chronic illness populations. And the author's definition of gratitude was a life orientation toward noticing the positives in life, including both thankfulness to others and a wider sense of appreciation for what one has. Next slide. So Beth Whitten cited this gratitude questionnaire, which I've not seen before, also known as a GQ6, as a resource on her blog. The score is positively related to hope, optimism, life satisfaction, forgiveness, sympathy, spirituality, religiousness, and pro-social behavior. Next slide. So the 6 questions are scored on a Likert scale, and the higher the score, the more gratitude you feel. Next slide. And I didn't comment, but back on slide 2 slides before, there is a link to the scale. So I don't know if that'll be shared, Stephanie, the slides after this, but I can also put it in chat if I need to. So these are the 6 questions that are asked on this scale, the GQ6. And note that question number 3 and number 6 are reverse scored. Next slide. And obviously on this questionnaire, the higher the score, the more gratitude one feels. So I wanted to look into some exercises that can help boost gratitude, some practical things that any one of us can do, or any of our patients or their family members. And there was a whole host of exercises on the web, but this slide lists a few of my favorite. One is journaling. Another is kind of some type of display, like putting your gratitude items in a jar or on a gratitude tree, or even carrying a stone around with you to remind you to note something that you're grateful for throughout the day. A gratitude amble is just taking a walk and noticing with fresh eyes what's around you and being grateful for the things that you see. Meditation or visualization, I know a lot of the social workers on this call probably do that with their patients. Volunteering, helping others, I think we all know this. Most of us are social workers. Helping others can make you feel better. Oh, and I see a note from Stephanie that the slides will be posted on the ESRD NCC website, so you can get to that gratitude GQ6, or you can just Google GQ6. It's easy to find. Volunteering, as I mentioned, and then a gratitude chain, and I'll just kind of, I had not heard of a gratitude chain, so we'll look at the next slide. So at holiday dinners or any kind of gathering with friends or family, a gratitude chain is where each person says one thing that they're grateful for, and it helps to create a positive atmosphere for the meal. So I think I'm going to be trying that at the holidays with my family this year. And my final slide before the question slide, I was also researching quotes related to gratitude, and this one really spoke to me. It's become a great affirmation to start each day with, and I've been doing that all week. This is a wonderful day. I have never seen this one before. And of course, that's Maya Angelou. And that completes my very brief teaser on gratitude and how to measure and how to boost it. Thank you.
Thank you, Lisa. I love that. Perfect for this time of year, absolutely, you know. I'm gonna pause just for a moment. Ann Pugh has put something in there. She came across an app, Silent Walking, trending on some social media apps. So you could take a look at that. Thank you, Ann, for sharing that out with everybody.
Thank you, Anne. I actually do that every day myself.
Yeah, I think walking's a great way to clear your head and have some me time. So any comments or questions? Oh, there's, yeah,
Oh.
here, Lisa, you've got one in from Diane. Your
Thanks,
thoughts
Diane.
yeah, how to use that.
I mean, I think what we would do is I think it would create some sort of awareness or affirmation if someone has a high level of gratitude, to kind of self-examine and then maybe look at some ways to boost gratitude. There was interreliability. It's an instrument that is considered reliable for use with any population. So there might be something online on how people have measured it, but I would think remeasuring after someone's tried some gratitude boosters might be helpful. And then I see from Natasha that they did a gratitude bulletin board at the start of Thanksgiving using turkey feathers for staff and patients to write on. And I have a comment from Justin. Thank you, Justin. Yeah, and so, and Anne's provided the link. Thank you, Anne.
Yeah. She dropped that in there for anybody to grab, take a look at. Okay. Well, I think we'll move on to Riquelen. Oh, there you go. There's Lisa's contact information. If you do have any questions, you can follow up with her.
Thanks, thanks, Stephanie. Thanks, Lisa.
At Network 17. There you go, Rick.
Great, thank you. Can you hear me okay?
Yes.
Okay, great. So hi, everyone. My name is Riquelen Ngumezi, and I'm the Patient Services Manager for Network 17, which covers Northern California, Hawaii, Guam, the Northern Mariana Islands, and American Samoa. Next slide, please. So for this talk, I'll be focusing on best practices. We recently wrapped up our first PDSA cycle with our project clinics. So we reached out to our high-performing facilities, which are those with a higher percentage of patients who screened positive for depression and accessed care from a provider who billed Medicare for services. We also contacted project facilities that were successful in supporting and encouraging patients to access mental health services through a provider outside of their dialysis team. Staff at the high-performing facilities and the select project facilities were really happy to have their efforts acknowledged. So they let us know that they discussed what's working during their QAPI meetings to reinforce and continue their best practices. Fortunately, they shared a lot. So I organized my brief talk by highlighting the most common or strongest best practices by the type of facility that shared a response. Next slide, please. Most of our independent clinics are outpatient hospital-based facilities. All of them credited their integrated care model for their strong teamwork and ability to easily and quickly communicate with other providers, which helped each provide more meaningful follow-up. For example, in the hospital, they have adult psych, behavioral health, chronic condition management, primary care, and nephrology, among others. So you have multiple providers who follow up with the patient and their care partners. 2 facilities have social workers who reported that their nephrologist and the primary doctors flag or notify them when they start or adjust the patient's antidepressants so that the social worker and dialysis team can follow up and monitor how the patient is doing with the adjustments since they see them more frequently, which I thought was great because usually it's a one-way street with the dialysis team letting the primary doctor know, but they described situations where it was a two-way street. So this helps the teams get ahead of potential issues like the patient stopping the medication because of side effects that they might be experiencing. And also, as a side note, this kind of communication also helps support the social worker to feel like a valued member of the team. Staff at most of our hospital-based programs who shared best practices reported that they incorporate mental health discussions upon admission with both patients and their care partners. And they said that this really sets the stage for normalizing discussions around mental health and depression. They focus on the patient's quality of life and who they are as a person versus their identity as a patient. They refocus the patient on how they can get back to or maintain their quality of life. They also reported that they support the care partners of patients who struggle with depression as they can easily burn out. And they often credit the care partners as a big reason why some of their patients are doing well. So they provide the care partners with respite ideas, maintain open communication, and get to know them as people instead of just as their main role as care partner. So I asked, they're already really busy. How do they do that? And they said that it sometimes just simply involves checking in on how the care partner is doing as well. So it didn't take up as much time as I thought it would. Next slide, please. Okay. Most of our LDOs or large dialysis organizations are DaVita facilities. And DaVita has an integrated kidney care program or IKC and social work counseling pathways program or SWCP. Our high-performing LDO facilities reported that their IKC nurses help provide more intense coordination, assisting with setting appointments, medication management, monitoring labs, and helping the patient navigate a complicated health system. Most also include patients in their social work counseling pathways program, where the social worker meets with the patient over a few sessions. They administer the stress thermometer and then rescreen with the PHQ-9 again. For some patients, this helped them be more comfortable accessing an outside provider, or it helped them move from being completely against it to being open to considering it, which, as we all know, can be a big win for some. For others, it helped the patient develop stronger coping skills, which was another focus as well, because sometimes certain words can trigger some patients. So when they talk about coping skills, that can sometimes help open the door for conversation around depression. Staff reported that SWCP helped increase hope, broke down bigger goals into smaller, easier to attain goals, and helped identify what is within the patient's control. Most of our LDOs also reported having very proactive nephrologists who bring up coping, mental health, and depression when they rounded, during care plan meetings, and also with patients' families. Several reported that their nephrologist was great at reminding about the patients and families about specialties and what the benefits would be for the patient to see a licensed mental health professional. Some strongly encouraged the patient to establish care with a primary doctor and reminded them the purpose of primary care. Several of our LDO teams reported using a tracker for patients who screened positive for depression and how that helped when reporting aggregate information during QAPI, which helps keep the topic of depression top of mind for the whole team and not just the social worker. We have one FA, facility administrator, who reported project resources and better focused attention on referring patients to their PMDs or primary care doctors has shown at least 10% of my patients receiving more focused mental health support through their PMD's office since starting their project over the nephrologist. So I thought that was great. Most LDO providers also reported directly addressing stigma with patients and staff. Several reported using the American Hospital Association's People's Matter, Words Matter resources that the network has shared a few times over the past years. This has helped boost staff confidence in how to approach and also respond to patients who may be depressed. Some social workers reported that they compile a list of mental health resources in their local community and have them readily available in the lobby. So that way, patients and care partners can easily access them without having to ask staff, which is really helpful for those patients who dialyze on first shift, nocturnal, and Saturdays. Next slide, please. Okay, these are our top responses from our high-performing medium-sized dialysis organizations. All of our high-performing medium-sized dialysis organizations reported having very strong and stable teams with low turnover. This really helps with continuity of care. They reported that most of their staff have developed long-term relationships with their patients and the families, which increased trust and sense of community. It also decreased feelings of isolation. This in turn has also helped them address stigma as well. They reported heavily relying on a whole team approach from the admin assistant to the technician, nurses, and clinic manager, so that it's not only the social worker talking about depression and providing follow-up. I even had a couple of clinic managers who said that they round regularly at least once a week on all shifts. Some also have good relationships with transportation providers who notify staff on any changes that they observe with patients as well. In addition to having proactive nephrologists, they also reported having strong relationships with local primary physicians, which also helps to make follow-up a lot easier. Several teams reported referring their patients to organizations that provide culturally relevant interventions or organizations that focused on providing services targeting their patient's culture. Many have patients who don't want to use an interpreter with a therapist, so it's really helped to have a provider who can speak their language and understand their culture. I have a couple of teams in Hawaii who reported referring patients to organizations that offer ho'oponopono, lomi lomi, aipono, and hula. Ho'oponopono helps to work through issues that cause distress or trauma, supports connections, and restores balance in relationships. Lomi lomi is a native Hawaiian physiotherapy and massage that can help decrease stress and help relieve pain. Aipono is healthy eating that can support kidney health, blood sugar, and blood pressure control. And hula is a native Hawaiian dance that can improve range of motion, mobility, balance, and flexibility. Hula also helps provide increased social interaction and strengthen community. There's even an insurance provider on island that provides, or that's primarily services Medicaid patients and some with Medicare to cover those services. Other best practices that they reported using that I also want to share are that staff reported working with patients and their family to plan ahead for more potentially sensitive times, like right now, like the holidays and also anniversaries, times when they know that the patient may be more down or stressed. Examples include having a plan, having loved ones or even staff check in more regularly, and also coming up with new traditions. And lastly, providing staff training on a regular basis, especially as they have new staff coming in, or maybe staff are working a different shift than they normally do. So providing staff with training on a regular basis about topics related to mental health, including depression, which helps increase staff confidence, address stigma, and also supports the whole team approach. Next slide, please. That's my last slide. Thank you.
Thank you, Riquelen. just looking at, is anybody got questions or comments they'd like to ask Riquelen? They can drop it into the chat. I know Network 17 Riquelen, you do definitely with the Hawaiian Islands and the Samoan Islands up there have some very diverse populations. So interesting that you shared that about the Hawaiian culture. I like that.
Thank you.
Just some nice kudos for you floating around out there. Yeah, great job.
Oh, thanks.
All right, well, we're going to move on to Ann Pugh from Network 18, Ann.
Hey, thank you. Next slide, please. So you guys may recall a rather lengthy call from last year that I spoke on about depression, and one of the things that really struck me when this project hit the statement of work was that, in a way, my entire career as a social worker in dialysis has been every moment of every day trying to get people to get the support to be able to make it through a difficult treatment, especially in center, difficult disease cycle, difficult comorbidities, loss, the whole business. So this is a slide that I stole from my previous talk. And pretty much this is I mean, every moment of every day, every time we talk with folks in clinics, we're building a community, and how we approach patients and ourselves and how we honor the relationships, it all makes a difference when it comes to people finally saying, if it is, it's finally reaching out for help when it comes to depression, mood changes, coping, things of the like. I have a colleague, Vernon Silva. I don't know how many of you guys know him, but one thing that I just love that he says to new patients and anybody who's done admissions is that, the new patients, they have the deer in the headlight look very, very much. They often are not processing what we're saying as we kind of go through the consents and try to be kind and present. And Vernon told me that one thing he says to new patients is that, at the end of all the signing, he'll say, look, I'm your social worker, and I know you probably didn't get everything that I said and all the paperwork we just went through, but I want you, when you look at me and you look at my forehead, I want you to think of written on my forehead the word coping, because that's what I'm here for as your social worker. I'm here to help you cope, whatever that entails, whether it's supporting you as you make a decision that may be unpopular, whether it's coping with mood by using marijuana. Of course, I don't think he would mention that because of federal stuff, but you know what I mean? It's like whatever I'm here to walk with. And I just love how he puts that. I like the image of the word coping being on my forehead, because that would it brings it down to brass tacks for the social workers in clinics. And it also differentiates us from others in the team. Next slide, please. So bringing this project to social workers that had some reactions as I did was interesting because, of course, by the time we got the, excuse me one moment. Right. By the time we got individual data from our first lists, right? The social workers, when we spoke with them on our calls, some of them were like, "Oh my God! I mean, these are patients that I've known for years would really benefit from joining a group or walking or going to see a therapist or going to a men's group or any of these things that we suddenly here's a network from outside saying, hey, we've put your facility in a project as a focus facility, which no matter how we call it, means that you somehow as a social worker in the facility perhaps have not been as successful as others in getting your patients to accept treatment for depression. So we had a few backs up a little. I mean, I don't know. I got to get reactions similar to the ones that I put on last year's call. And so now that we've been through it, I've had a chance. I spoke with all 10 facilities last month saying, so now we've gone through it. We had that kind of first call where social workers, one actually kind of said, well, this patient isn't depressed anymore. Or what the heck, this patient expired. Why are they on your list? And I was like, just over and over, I was like, just take this. It's so important. The incidence we all accept is high of depression in our population. It has a lot to do with how people do. Social workers already who of course are the core group that we worked on for this project, are social workers already adept at reframing things, right? We're already adept, just as Lisa said, with gratitude. It's like you can look at everything you've lost, or you can look at this new day that you haven't seen yet today, right? So part of what from early on, I was like, look, so someone expired, well, that's fine. Let's just kind of not get lost in the weeds here and take the themes and the ideas of this project. So I got all kinds of interesting kind of write-in feedback. Some social workers really liked this project. Actually had numbers and data and lists that came from outside, from CMS, that had to do with reimbursement, right? Whenever you're talking about billing data, billing resonates. It's something where as people, I mean, I remember when I first started in dialysis, I literally had a doctor once saying, what's a social worker doing in this meeting? And that has changed. And social workers have done a lot of advocacy over the years. But this project now coming in with data saying, hey, look, you know, this is a large number of folks who screened positive and we didn't see follow-up. Let's work it as a group. I think it was very empowering for social workers. Let's see, it created new linkages. I think it's overdue that we look at linkages with outside, I mean, like the HRSA-run community health centers. I mean, there are health centers where people go for years now in the community for those who don't have insurance that will help you apply for Medi-Cal, get help with your diabetes. Why on earth have we not kind of tapped into this earlier? Along with the same EHR, there should have been linkages between these centers and the EHR at the hospital and the dialysis centers a long time ago, on which the social worker could put in a PHQ-9, or the hospital could put in a postnatal depression score that was high, and it would trigger their primary to see that there's a depressed mom who just had a baby who, gosh, could be on dialysis. It would kind of have that loop. Next slide, please. Some social workers felt that their talking to the patients was not that valuable. They felt like the patients had had enough of the professional follow-up. But it also enabled them to get patients involved because more people in the facility were talking. And also social workers reported that they had, in trying to kind of do what we were asking, to try to move the dial on these patients that for whatever reason, cultural, whatever, were not getting outside, you know, the 50-minute hour, found other benefits through having the conversation. Next slide, please. There was these are some responses about the project in the beginning, and things like, what are things that you would like to tell us now that you've been through this with a 4-month PDSA cycle? And one just said, you know, hey, we do so much already. There's already a lot of pressure. This is known. This is not new ideas that with better mood and coping and gratitude support, that patients will do better. So, but that being said, then there were still asks for the networks to do. So the handouts in multiple languages, and also a formal letter. We did use that referral form that Justin spoke of in the recent call, that was used to notify a primary that, hey, you know, your patient that's coming to see you shortly did screen positive for PHQ-9 last year, and if you wouldn't mind kind of touching base with them as you review whatever it is you guys are having a current appointment about, that would be much appreciated. Because our patients do every so often go in to see their primaries, maybe for an upset tummy, or why isn't their foot healing? So if we know about that, that's something, again, ideally through an EHR would be easy, but instead we created a form, and one of the social workers really liked that. Next slide, please. And that social worker said to me she was astonished that a primary called her and thanked her for the referral. That was probably the most exciting day I've had in a long time. I think I just almost fell off my chair, but I thought that was great. And so these are a summary of other ways that this project and depression can be addressed. There are so many ways to help with depression, mood, anxiety, any of the things that can get to a interference in quality of life issues in our patients, and then that may not necessarily need a 50-minute hour. So this is not anything new. The slide deck will be shared. Thank you for your time. Oh, sorry, this is the happiness calendar. The Greater Science, Good Science Center does research and gratitude in UC Berkeley. Google it. Enjoy. Thanks, everyone.
Thank you, Anne. I've seen this calendar before. I think it's great. I really like it. I'm glad you brought that up again. It's been a while since I've seen it or somebody talked about it. So that is really, I really like it. So
yeah, you can subscribe and they send you a newsletter.
Yeah.
They also have like a parenting newsletter and stuff. So it's cool.
Oh,
Thanks.
that's awesome.
Yeah.
Yeah, a lot of nice congrats going on in the chat, along with some little emojis. So just a real quick to wrap up here today, our polling question. Now that you've heard these presentations, what will you implement in the next 60 days? So just thinking about that, because that's what all these Learning in Action Network calls all are about, something you can take away, something you can implement. Think about that, drop that in the chat. There's the QR code to the change package. I also dropped our website link in there too, so you can go and visit us at the ESRDNCC.org, and you can click on the professional side, and on the right-hand side, there'll be all the change packages. Communicate with the PCP, great, thank you. Working more on continuity of care with the IDT, the G6. Making sure the lobby has flyers on mental health resources. Right, great, thank you. I think there's a lot of great best practices today that you can take away that everybody can use and implement in their facilities. So just a last closing call. Again, we just like to post our social media. We really want people to join us, get involved. We're on Facebook, Instagram, actually X now, we'll have to update that. YouTube, join us and like us on any of those social medias. We would really appreciate it, and we would like to hear from you. And I want to just thank everybody, our speakers today. Great information, a lot of good best practices, and happy holidays to everybody. I hope whatever you are doing, you have time to share with friends, family. Be grateful. Thank you, Lisa. I think that's a great idea. I'm thinking about my own Christmas dinner. I think it's a great way, you know, for something for us to share. So thank you so much. A lot of good, it looks like there's a lot of good people are going to be taking some of these best practices and implementing them. So thank you again. This concludes our call. Appreciate all of you taking some time out of your day today. I appreciate all the speakers for their great presentations, and everybody take care. Bye-bye now.